Welcome back, everyone, onto the online platform again. We've got something really special for you today. So on the sofa in the studio, we are welcoming Simon Payne, who is a consultant neuropathologist from Nottingham University Hospital's NHS Trust, Matt Luce, who is a researcher just up the road in Nottingham, and we've managed to tempt our CEO, Gordon, into the studio as well, because Gordon feels really passionate about the project that we're going to be talking about today, and we want to integrate his views into this. So Simon, thank you for coming to join us. The reason we've asked you to join us today is because 10 years on from London Calling's first outing, this year we have Friday, we have a clinical and biopharma day, and you're actually talking tomorrow rather than today. But the themes of the talks today have been going from the bench towards the bedside, and you have got a really exciting project that you're going to be talking to us about. But first, I'd love you to just quickly explain what is the role of a pathologist and why is genomics changing the way that you work?
Yeah, so I'm a neuropathologist, so a sort of pathologist that just deals with the nervous system. And people have this idea that pathologists are people who just deal with the dead. And we do that, but it's a very small part of our job. The majority of my time is spent actually looking after people who are alive, so I don't see the patients myself, but I do see the tumour samples, for example. So my job is to really take those samples, to analyse them using different tools, and to predict what the future has in hold for each patient.
And why does genomics make your job different?
Well, as we've understood more about tumours, and particularly brain tumours, we know that the molecular changes, the changes you can't see down a microscope, be it methylation, copy number changes, fusions, single nucleotide variants, etc., those are the things that so powerfully predict a patient's future. So as a pathologist, particularly as a neuropathologist, we're seeing at the moment, we're going very much from using a more traditional microscope to make these diagnoses and predictions to using much more complex molecular changes.
Fantastic. And could you share with us a little bit about the amazing project that you guys are doing up in Nottingham at the moment?
Yeah, it's a real privilege that over the last 18 months or so I've been working with Matt very closely, because what we really need for our patients is that comprehensive idea of the molecular changes in the tumour. And we can do that through standard care pathways at the moment, but there's a significant wait that comes with that. So if you're a patient who's had a tumour taken out or biopsied, then there's a wait of several weeks before we get those changes back, so that we can then comment on them and make that diagnosis, classify the tumour. And discovering Matt and his fantastic abilities was fantastic, because through Nanopore we can classify tumours incredibly quickly. I mean, quickly compared to the weeks that we've been waiting, but we can actually now do it within a couple of hours, which puts it into the intraoperative timescale. So when the first thing a patient has in terms of treatment is actually the operation. And so if we can guide that operation based specifically on the changes in that tumour, then we're giving that patient the best chance they can.
Fantastic. And this is a research programme that's moving towards practice. And in the future, if we're able to get this into practice routinely, what would that mean for the families?
Yeah, it's a good question. There'll be impacts all through the health system for my clinical colleagues, but for the patients and families in particular, who now, and I don't know if we all in our personal lives, we meet diagnoses, things like this, and I've had to wait for some in the past for family members, and I know what a horrible thing that is to have to wait. And so to be able to have a diagnosis, to have a tumour classified with the help with the Nanopore, would just be transformative for the patients, but also for things like the healthcare system. Things can happen a lot quicker, the right decisions can be made up front rather than waiting for weeks to have to make those decisions.
So speed matters for anxiety as well as for outcomes, is what you're saying?
Yeah, I think it's speed, it's accuracy, it's efficiency. Those are the things that this work delivers.
And Gordon, you've always been really passionate about the programmes that are using Nanopore for rapid analysis of cancer. Can you share why that is?
Sure. I think I'm coming from a point-of-care background and helped to radically transform the lives of type 1 diabetics, bringing the clinic to the home and giving analytical quality data to patients. Was a bioelectronic play I was involved in, and when it came to genetics, the canvas is much bigger and it's a much harder challenge to look at the underpinning causes of disease. Now, I'm a chemist by training, and there's one thing I do understand, and that is chemical corruption of DNA. So methylation to enable rapid real-time insights in brain tumours that would be something I would have written down as a Christmas present to myself 20 years after we launched this technology. And it's happening live, and it's just so humbling to see how it's transforming healthcare. It's just awesome.
Fantastic. Well, so Matt, obviously you're a researcher. How does it work? How do you and Simon plot the journey between the fundamental science into an implementation pathway?
That's a great question, and I think because this hasn't been done much before, we are doing something for the first time. We're kind of having to navigate the way through, and what are the decisions you have to make, what are the impacts, what are the steps that are important. Logistically, we've had to work out how to handle samples, how to move them, and then practically, how do you best report this information back to ultimately patients? That's the long-term goal. There's all those validation steps you have to go through, checking everything's correct. And so it's quite a journey of learning from my side what's needed in the clinical side, and also understanding how to apply the knowledge that we've built up in the lab over several years, and transferring that into a clinical day-to-day lab where it has to work first time every time.
There's no margin for error.
There's definitely not margin for error, yeah.
And is the research funding structure clear for that, or do you have to dip into different pots of money, and does that use up a lot of your time?
That's a really good question. The funding pathway for this is not clear. We have been able to get support from various different places, and interestingly, it's the impact on giving that answer back to the patient quickly, which is where our current funding is coming from, and looking to see how we might be able to do that and how best to do that. So there's definitely, there are lots of people who would like to see this happening at a bigger and bigger scale, and that's one of the things we're working on at the moment.
Cool. And talking of skills, Gordon, you've just given an amazing, inspiring talk to the STEM students upstairs. And one of the parts of that conversation was all of the varieties of skills that you can have in a scientific career, whether that's research, entrepreneurship, or of course there were a few students upstairs interested in medicine. What do you think the students upstairs would have thought of this program?
I genuinely think they would be blown away. It's still in the classroom. What do you think you are, a brain surgeon? That is still regarded as the most highest art of all. And interoperative, in real time, really helping kids. It doesn't get any better than that. I'm really jealous. It's not very often I say that, because I love my job.
So you had an incident recently, didn't you, when you gave us talk to a school? What happened?
I think there is something about this technology, and particularly applying it, as you say, to potentially children with brain tumours. It really captures the imagination. And I went to talk to one of my kids' schools recently to the year 12, 13 students, and it was just great being able to talk about this project, the impacts that everyone can see it's going to have, but being able to say to the children, or young students, young adults, who wants to be a mathematician? Who wants to be a chemist? Who wants to be a physicist? Who wants to be a computational person? That's the people that develop this technology that allows me, as the idiot doctor on the end of it almost, was sat in your chairs. And that really got conversations going, I know, at home with those kids. It's fantastic. From my perspective, one of the great things about this project is that my problems were Matt's solutions, and his solution were my problems. It's just been an amazing project to work on. I've got these samples that I can't classify in a timely fashion. Matt's got this amazing expertise, great platform, but couldn't access the samples. And together we've done incredible things.
Well, that's maybe the network effect. Certainly, Gordon, we've always talked about putting London Calling on so that we can help people form connections to solve problems. What's next? How are you going to use the network effect to accelerate the science, not just for the people of Nottingham, but beyond?
So we're hosting a day on the 27th of June in Nottingham, where we are taking through the whole process and explaining to people what we do. That is open for people to come along to, and we've got so many people coming from different hospitals in the UK, it's untrue, but we also have people coming from a lot further afield, across Europe, and I think we're getting we do have a registration from someone in Australia and someone in New Zealand, and this is an in-person only event, so clearly there's a lot of interest. We are talking to people around the world all the time about what we have been doing. Recently I spoke to Tip in Bangkok, who was here last year, and we talked about how she's already doing some of this sort of stuff, but how we might work together and help. And I think the overarching thing about this project is simply how can we get this to impact patients efficiently, effectively, reliably as soon as possible. It's been quite eye-opening from my perspective. We've been running these classifications on samples. We're up to about 90 that we've looked at now. And we know the outcome for these patients, but it's research only. We're having to wait for the standard of care to come back. And you very quickly get yourself into a situation thinking, well, how can we move this forward?
Fantastic.
Because it will make such a difference to patients. I get frustrated as a researcher waiting 6 weeks for an answer. Imagine what it's like for the patient.
Well, I remember this time last year, and you just unboxed your P2,
Yeah.
and you and Tip were talking about putting a P2 in every cancer unit in Southeast Asia to do projects exactly like this. So Gordon, what's the vision? How are we going to enable everyone to do this?
So 10 years in, this is the perfect example of moving into mainstream. In order to do that, we need Q-Line, and that's coming. We're going to work with Matt and the bioinformaticians. We're going to get one unified workflow here, sample to answer, and we're hopefully going to start making a real dent, as Steve Jobs said, in this universe of kids with brain tumours.
Fantastic. So just before we go, we've sat on the sofa in this order because there is a bit of a football problem on the sofa here. We have an Arsenal supporter at one end of the sofa and the Tottenham supporter at the other end of the sofa. Are we going to be friends at the end of the day?
Well, I'm very happy we managed to ensure that you didn't win the league title. That's what a Spurs fan gets you.
Thank you for that. Yeah, very kind of you.
And with that in mind, we're going to hand over to our next talks. They are all fantastic. Enjoy the afternoon.